to know about stroke. And I would put this into Manitoba's perspective because that's what makes sense to us, correct? What do we do, how do we do, and what do we need to know about that, correct? So here are my disclosures. Nothing is related to what I'm going to talk about today, but I'm supposed to do this for my talks. Here are learning objectives, and starting with stroke. I'm pretty sure either you guys have seen someone in your family or in your surrounding, in your neighborhood, somebody having stroke. And this is a common condition that most of us are aware of. I'm going to test you guys. Do you think this is the stroke we are talking about today? No. How about this one? I don't think so. I see David shaking his head. Thank you, David. What about this one, David? How about this one?
No, no, no.
Uh, okay.
That's that's fleas.
How about this one? Kind of. Right.
Maybe
This is,
that's after the stroke.
yes, it's after the stroke, right? So this is what we see. Half of, like, when we talk about stroke, one thing that comes to our mind is half of the body is affected. That's like the common concept in our mind. Well, World Health Organization defines stroke as a condition caused by interruption of blood supply to the brain. And this can happen when either when the blood vessel bursts, called hemorrhagic stroke, or if the blood vessel is blocked, when it's called ischemic stroke. It's very important. These two are vast topics, so it's very important for me to tell you that we are going to talk about ischemic stroke today. Okay, and that's the kind of more common type of stroke that we are aware of. Roughly 85% of the stroke that we see are ischemic stroke. Only around 15 to 20% of strokes are hemorrhagic stroke. How common is this? Every 10 minutes, someone in Canada suffers a stroke. So you can imagine. Over 14,000 Canadians die from stroke each year. And every year, more than 50,000 Canadians experience a stroke. And the worst part is that more than 300,000 live with the ongoing effects of stroke. And that simply reflects the degree of disability, amount of disability that stroke causes. It's not just kill the people, it leave them disabled. And that's very important. Okay, the question is, so what will increase stroke risk? Over the next 10 years or so, the incidence is expected to increase because our population, overall population, is growing older, and also because of the rising prevalence of diabetes and obesity. This second point is even more important in Manitoba's perspective because it has been shown that Manitoba has higher than national average incidence of diabetes and obesity. Cost This cost the Canadian economy at least $3 billion annually, and up to $8 billion in the next 20 years. So it's pretty expensive thing to take care of. Right? So we'll talk about what do we do actually. And it's very important to remember that when stroke happens, it doesn't recognize who you are, how old you are, which background you come from. It Even the kids have stroke. The youngest kid I saw around 4 or 5 months back was only 5 years old. He came to our hospital with stroke. So how do we recognize stroke? Well, most common symptom is the sudden onset of weakness or numbness of the face, arm, leg. And remember that cartoon picture I showed you, it affects most commonly only one side of the body. And symptoms of stroke depends upon which part of the brain it affects, which part of the brain is affected by stroke. I think most of you guys know that different part of our brain is responsible for different kind of function, body function. Like back of our head, we is responsible for our vision. So if someone is having stroke in that part of the brain, you know what they will present with? Visual problem, sudden onset of blindness. Similarly, the motor area is right up top here. So if there somebody's having some stroke in that area, they will have weakness. Okay. Some people also present with just confusion, difficulty speaking. So speech problem, vision problem, or difficulty in walking, holding on to something, loss of balance, coordination, and very rarely actually some people do present with headache as well. Okay, so this all depends on which part of the brain is affected. There are multiple ways we try to score the severity of the stroke. And one of the most accepted scoring system is this NIHSS. And this, you see this tiny print, you can see this is the expanded version of the NIHSS, or National Institute of Health Stroke Scale. None of us need to know any of these. Correct? Why? Who will have time to find about these? But the important thing to remember is this severity scale actually assesses five main areas: the mental status of the patient, speech of the patient, motor and sensory deficits, vision or neglect if they are getting affected. But this is mainly for highly qualified medical doctors who are in the emergency department, who will have to go through all of this. As a general public, we do not need to know this, but we also need to know why do we have this complicated scoring system. It's because based on the scoring system, we may have mild, moderate, or severe stroke. And why do we need to know this? Is because milder stroke, that is the patients who have NIHSS score of less than 15, you know what happens? 80% of patients end up having good or excellent outcome. And that's why we need to know. Right up front, we need to know which patient is going to have good outcome. And also we need to know which patient is having going to have bad outcome, so that we give them more intense treatment. Okay, remember this NIHSS of 20 or above usually have only 20% chances of good outcome. And this is the type of stroke that I get to treat more often, more severe type of stroke. Okay, and I'll show you a little bit more about this. Well, what is more important, because that complicated scoring system is, it takes time and takes expertise to evaluate, we have a simplified version. And this is the version our ambulance drivers or EHS personnel use in Manitoba and many part of the world. And this is called LAMS, Los Angeles Motor Scale. And it's very simple. Only three things need to be assessed: if the patient is having a facial droop or arm drift or grip, how good is grip. And based on this, the scoring system can be anywhere between 0 to 5. 4 and 5 are severe stroke. NIHSS of 4 or 5 means very severe stroke. And what does that mean is these patients have a higher likelihood of getting one of the major blood vessels supplying the brain occluded. And this is where I come into play, where we go into their brain and pull that clot out to make them better. Okay, and this is very important for our ambulance driver, because they are all trained that if the LAMP score is 4 or above, these patients need to come directly to the Health Sciences Center in Winnipeg, so that these patients can receive timely treatment to get the best possible outcome. Okay, And this is what we all need to know. You must have seen this is the Heart and Stroke Foundation logo for called FAST, and this is what we all need to know. Okay, what does that mean? F stands for face. If someone's face is drooping, and if someone can't lift their arm, or if someone is having slurred or jumbled speech, it's time to call 911. Very, very important. I want to emphasize this point that you have to call 911 even if you know that someone is having stroke and you can drive that person to the nearest emergency. Do not do that, please. What is most important is call 911, because remember that scoring system I showed you? Our ambulance drivers have been trained to assess which patient should go to which hospital. If you are driving the patient to directly to the nearest hospital, that hospital may not be the right hospital for that patient based on their stroke severity. And this is very, very important to remember. Call 911 as fast as possible, because the quicker you act, the more of the person we can save. Okay, with this background, let's talk about how does it work in Manitoba. Okay, but this is what we need to understand the most. I'm assuming most of you or all of you are look based in Winnipeg and in and around Winnipeg. No, okay. David is shaking his head. Okay, perfect. Then it's even better, because then the story I'm going.
No,
Go ahead, David.
towards the west.
Okay, so the story that I'm going to tell, maybe most many of you will relate to this. Okay, let's look at travel across Manitoba with one of our patients. Okay, she gave me consent to use her story and her picture to spread the story. Okay, Mrs. VL. Some of you may recognize her, just ignore that part. And she was 89 years old, living independently at home, and so independent that she was alone in her own home and she was shoveling the snow. And this is a story of late November last year. She was getting ready for the festive season, and she lived in Verdun. Okay, so this is the story starting from Verdun, long away from Winnipeg. Okay, she was getting ready, and one of the her favorite thing to do is to make pajamas for her 20 grandsons, grandchildren, and great grandchildren. Okay, and she was getting ready for this, and she was on anticoagulant, which many of our folks in that age group may be on anticoagulant, and she had to go to the hospital because she experienced bleeding, GI bleeding. Okay. Of course, anticoagulant was stopped because she was bleeding, so we don't want her to be on blood thinner. So anticoagulant was stopped. And 2 days later, in the hospital in Verdun at 1 a.m., in the middle of the night, she developed a left body weakness. She could not even lift her hand. So zero power on the left side, and she had slurred speech. So remember, the scoring system, Lamb's scoring system, she was Lamb's 5. What does that mean? That it's very likely or highly likely that she is experiencing one of the major blood vessels to the brain blocked. Okay, it's very, very important to recognize the stroke. You remember the FAST, I'm repeating this, FAST logo. If you find someone with having face drooping, arm weakness, speech slurring, call 911. This patient, our lady, was in the hospital, so she was recognized right away. And we had to move fast, because you know why? Because once the stroke starts, 2 million brain cells die every minute, and I'm pretty sure nobody has spare brain cells to let die. Okay, and that's why we need to be work fast. We means you, us, the medical system, the whole system needs to move really fast. Okay, so it was stroke was recognized, and the patient needed to go to the nearest primary stroke center, and the nearest primary stroke center from Verdun was Brandon, 50 minutes drive. Patient went to Brandon and got a CT scan of the brain, CT scan and CT angiogram of the brain. And by 4:30, remember what was the time of onset? 1 a.m. 4:30 a.m., 3.5 hours later, she is in Brandon with her scan done. Okay, this is her scan. First thing that we need to know is there a bleed?
Mm.
The answer is no. There was no bleed. And the next thing we need to know is these are the blood vessels on the CT angiogram of her head. And you see what's going on here? You look at the left, this is the right side, this is the left side. Left side, you see the blood vessels are all flowing well, but the right side, this blood vessel has stopped. So this is the problem. This is where her blood vessel has been blocked. And this is the major blood vessel that is causing her whole left side of the body weakness. Okay. Now, question is, she's 89 years old. Should we do anything, or maybe that's it? Well, we don't think like that we don't consider age as an issue because she was living independently, so she deserves all the care we can offer to her. Okay, and there is a good rationale behind it. So, and this is the rationale for some of the people in healthcare administration or politicians who should know why caring for these patients, although it looks expensive to begin with, is actually not expensive. And this is what I'm going to show you. If someone is having stroke, there is a chance that 1/3 of the patients may have good outcome, depending upon the severity of the stroke. Half of those patients actually live with disability. Okay, and one like 20%, 1 in 5 patients may die. What is important is these people who become disabled, the system spends roughly $100,000 per year to care for these people. Okay. And to make one of these patients independent, it means moving these patients from the red group to the white group cost us around $50,000. Okay, what does that mean? That means if we can make one patient independent, make them not disabled, then that will cost the system close to 60, that will save the system close to $60,000 per patient per year. And no other treatment, and I mean this has been published as well, no other treatment will save this much of amount of money per patient per year. And this is why treating stroke is actually saving healthcare dollars. So let's talk about Our Lady. She was 89 years old. Remember, the first thing that we can offer any stroke patient, because the artery is blocked by the clot, we need to remove the clot. And the easiest thing to do is, you have seen the Drano. Okay, we call it Drano of the brain. This is called TPA. This is a clot busting drug. Okay, we can offer this drug up to 4.5 hours from the time of onset. Remember, in Brandon, she was 3.5 hours from the time of onset. Correct. So she is still within the time window for to receive this Drano of the brain called TPA. Only if she doesn't have any contraindication. But remember, why was she in the hospital in the first place? She was experiencing GI bleed. If somebody is bleeding, we don't give more blood thinner. So she has contraindication for TPA. So she can't receive that first line of treatment that our system has to offer because of her bleeding. Okay, so what's the next step? Next step is what we call as endovascular thrombectomy. This is my role. This is where I come into play. This is what I do for a living. Okay, so what do? We puncture the artery in the groin. We go from the groin, put a long tube called catheter that goes all the way, and we bypass the heart. We bypass the heart to get into the blood vessels supplying the brain. Here it is. And then we go put a tiny tube called microcatheter through the first one, and that goes up into the brain. Okay. And then what we do is we see this is the clot here. We put a tiny wire called microguide wire that crosses the clot. And then over the wire, we advance that tiny tube called microcatheter, and then we remove the wire and backload a fishnet called stent that goes and get deployed across the stent. And we wait for here for 4 to 5 minutes. Why? Because now there is a bridge, there is some blood going into the brain. And then during that time, the stent gets incorporated into the clot, and then we pull the clot out. And exactly like this, the way animation is showing you, this is how it works. And we pull out the clot from the brain on the stent. Like you can see, we'll take pictures of these clots when we pull it out. So this is called EVT. This can be done up to 6 hours from the onset of symptoms. Remember, Our Lady was 3.5 hours from the onset of symptoms. So what is the advantage of doing this? The advantage is, remember this graph I already showed you, only 1/3 of the patients get good outcome and 50% patients get disabled. When we use EVT, the treatment just now I showed, half of our patients get good outcome, and only 4 out of 10 get disabled, and it could potentially also save patients from death. Right? And the number needed to treat for this kind of treatment is 2.5. And it's very, I know it's a technical term, but just to give you a sense of what number needed to treat is. Number needed to treat reflects how effective a treatment is. That means the lower the number, higher is the effectiveness of the treatment. Okay. So if that also means how many patients we actually need to treat to get one good outcome. For stroke, it's just 2.5. Means 2.5 patients roughly we have to treat to get benefit in one patient. And this is very important because you put this into perspective. You might have heard of heart attack, correct? Cardiac arrest. That also we have to treat 2.5 patients to save one patient from dying. You get clot busting drug when patients come to the hospital for heart attack. To get one good outcome, we have to treat 43 patients. So remember how effective this treatment is. So EVT has become one of the most effective treatment known in the history of medicine. Okay, so this is how effective the treatment is to get a good outcome. So, well, Our Lady deserves that, correct? So she is remember, she started from Verdun, came to Brandon to get her scan done. We thought that give her TPA, but she was not eligible for it. But now she is eligible for EVT. But the problem is EVT only can be done in Winnipeg, in Canada, in Manitoba. So Our Lady has to be moved from Brandon to Winnipeg now. By the time we decided all these things, another half an hour has passed. I want to show you this time because remember, I want to repeat this: 2 million brain cells is dying every minute. Okay, so we have to move fast. We thought Our Lady could come to Winnipeg in next 2 hours. Maybe by 7 a.m. she should have been here. Okay, that was the plan. We thought, okay, she is only 3.5 hours from the onset of symptoms. EVT can be done up to 6 hours. By the time she will be here, she would be just under 6 hours. So she should come here and we'll get it done. Well, life happens. You know how much delay can happen in transporting people. By the time she came here, it was 8:30. 1 a.m. was the onset of symptoms. She could have received the EVT till 7 a.m. But beyond that, Now what to do? Because evidence suggests that only up to 6 hours we can do the treatment. But things are changing. Things are moving very, very fast. Back in 2018, we found there was another study which showed that actually the EVT can continue to be equally effective even beyond 6 hours and up to 24 hours in select few patients. Okay? And this is the select few patient is the key here. In select few patient can be identified by special imaging. So hey, our lady was here in Winnipeg at 8:30. Yes, she was beyond 6 hours, but we said, okay, let's see if we can do the extra scan. And this is the extra scan that we do. And the scan is called CT perfusion, which shows that this much of the brain, the red portion that you're seeing, is at risk of dying. If we don't do anything, all this part of the brain will die. But none of that brain was dead yet. This is a special situation. And this is good to know for us that, okay, that means there is a very high likelihood if we remove the clot, all of this brain that is at risk of dying will be salvaged. We looked at it and we say, hey, she's good. Let's go. Let's rush now. 9:30 a.m. We took the patient to our angio suite. Took another hour. By the time from the scan to our room, she was in on our table at 10:30. And remember, I showed you this picture before on the CT angiogram in Brandon. Is the same artery still occluded? Okay, so what did we do? We put this tiny tube. I showed you the video up here. That's called microcatheter. We placed the stent from here to here. I don't know if it's visible to you or not, but this arrow is showing the location of the stent just across the occluded artery. And guess what? We pull the clot out of her brain and the artery is open. Okay. So this is very, very important. And this is very gratifying because I see some of our patients improving on the table right in front of us. We pull the clot out. Before that, they can't speak, and now they're speaking. Before that, they couldn't move, lift their hand, and now they're lifting their hand up like that. And that's very, very good to see, good to know. And we like that kind of outcome whenever we can get. And this is our lovely lady. A day after, remember, she presented with, she could not move her left side of the body, and she had weakness of the left side of the face. Now notice if she has any of that remaining. Give me a smile. Big. Can you say cheese? Cheese. Can you puff your cheek? Awesome. Can you close your eyes? Awesome. Good job. Can you put your hands out there? Both of them at the same time. She could not move her right side, awesome. The in left front. Side at all. Put your hands in front. Like, yeah. Yeah, awesome. Good job. Go ahead, do that. Hands on the side. Okay, and in the front. And awesome. So complete recovery. She went back to where she started from. And this is what we hope for. And this is what we are able to do right here in Winnipeg for all of our Manitobans. And it's very important. Remember, similar to her, she came from Verdun. We fly patients out of Thompson, in the northern part of our province as well, and they get very similar outcome when selected well. And again, what is very important is the time. Time is of essence in stroke. Move fast, as fast as possible. And sometimes it's impossible to move fast because it has to take 2 hours to move somebody from Brandon to Winnipeg. And at times it takes even longer. We fly in patients not only just from Manitoba, but also from the Northwestern Ontario. Thunder Bay, Sudbury, we send Kenora, all those patients come to us because we are the closest center to provide EVT. Similarly, Eastern Saskatchewan patients also come to us occasionally. And this is very, very important treatment because it changes the outcome dramatically. Okay, so what we must know is stroke kills roughly 2 million brain cells per minute after the onset. And EVT, or endovascular thrombectomy, which is the procedure where we go get into the blood vessels of the brain and pull the clot out, is the new standard of care. We started only in 2015. Locally, we started in 2016. The evidence came in 2015, so it's still relatively new procedure, but we treat roughly 150 patients per year. And this can be done up to 6 hours, but read 24 hours because after 6 hours, it's all dependent on what the image shows, what the scan shows. And that's very, very important. Thank you. Questions?
Yeah. Yes, I have a question, Dr. Shankar.
Yes, Lana.
Yes, the information you presented was really good. I was my left eye blacked out in 2018, but my previous history, I had a heart operation a long time ago. I had an extra nerve around the heart, and I don't know if it's when I was born with that, and they took it off, and then my left eye blacked out in 2018 of October. But I've had several concussion injuries where I hit my head on the glass of the car, and I've had 6 whiplashes. Could that left eye that blacked out, they said I could have had TIA. Could it have been like, because he said it could have been a mini stroke. Does that sound familiar? Or?
Yes, yeah, it could potentially be a mini stroke. But in your case, it's difficult to say because you had several other things. You said you had several concussion and you had some heart issues. Any of these could potentially cause that problem as well. It all depends upon how it starts. Right? So in stroke, things start with a snap right away. Everybody will know that, oh, 5 a.m. this started. You cannot miss it. Okay.
Yeah, like I was my left eye just blacked out for 20 minutes. So I don't know what happened. I guess it was out of clock.